Hello, and thank you for stopping by my poster session titled The Curious Case of the Post-Traumatic Pseudolipoma. I'm going to be showing a clinical vignette about a young female in the Navy who developed a soft, fleshy mass at the site of blunt trauma. The post-traumatic pseudolipoma, or PTL, is an unencapsulated adipose tissue which develops at the site of acute or prolonged blunt soft tissue trauma. It differs from a traditional lipoma in that it is unencapsulated. It can take a round or fusiform shape and may have areas of saponification leading to fat necrosis. The reported incidence is low, with approximately 100 cases reported in total. These reports indicate that PTLs are 12 times more likely to be found in females and more commonly found in areas of high adiposity to include the hip, thigh, and gluteal regions. This incident disparity may be attributed to sex-determined adipose tissue distribution or cosmetic concerns leading to increased reporting. After doing a literature search, there are only 10 publications addressing this particular pathology. Most publications in the search results were singular case studies or case series of smaller scope. The common thread throughout all of them is the patient history, which universally includes a traumatic event resulting in a hematoma and subsequent latent period of several months to a year in which the pseudolipoma formation occurs. I'll now present my case report of a 27-year-old female who presented to the Family Medicine Procedure Clinic with the deformity of her right buttocks. She noticed a soft protruding mass months after landing on her buttocks on a stick during field training and was unhappy with its appearance. Prior ultrasound proved unhelpful in determining the etiology. On exam, she had a protruding 2 centimeter mass at the right buttock intergluteal fold, which was soft, compressible, and non-tender. There was no capsule, nodule, loculation, or sinus tract. The mass was flesh-colored. The patient underwent excisional biopsy with findings of benign appearing unencapsulated adipose tissue. The wound was closed without difficulty, and after 7 weeks, she had a well-healing scar and noted no contour deficits of the buttocks. Months following the initial repair, the patient re-presented to the family medicine clinic with recurrence of the fatty protrusion. At that time, she was referred to plastic surgery for a definitive management and improved cosmesis. There are two leading theories of pathogenesis that are described in the literature for post-traumatic pseudolipomas: the herniation pathway and the inflammatory proliferation pathway. Adipose tissue is comprised of fat lobules which are organized underneath supportive fascial layers. The fascia is elastic and allows for temporary changes in shape, enabling disbursement of impact forces. However, when the trauma forces exceed the elastic capacity of the fascia can lose its integrity. This injury is the basis for the oldest of the pathogenesis theories, the adipose herniation theory. As a result of the injured fascia, fat lobules are displaced through the damaged septa, which allow for the development of an epidermal pseudolipoma to develop in the site of blunt trauma. Multiple case series have reported this theory. However, this theory has been brought into question as more recent case series have found a larger proportion of PTLs with no identifiable disruptions in the fascia. These more recent case series have subsequently explored the inflammatory proliferation pathway. First introduced in 1997 by Signorini and Campiglio, they suggested that local tissue trauma leads to the release of inflammatory cytokines, which excessively signals the development of mesenchymal adipose cells into mature adipocytes. Studies exploring hematomas have found elevated levels of growth factors and inflammatory markers throughout the development and resolution of the hematoma. Adipogenic cells may be chemotaxed to the area of trauma, differentiated to white adipose tissue, and supported with developing vascularity. Thus, most of the post-traumatic pseudolipomas in the available research appear as de novo tumors and more congruent with the inflammatory proliferation model of pathogenesis. Treatment of the post-traumatic pseudolipoma is usually performed by surgical excision or liposuction depending on the size of the pathology. If liposuction is performed, it has been recommended that a biopsy should be performed to rule out a malignant liposarcoma prior to the procedure to prevent seeding of the malignancy. Sending the resection to the pathology lab may help evaluate if any damage to scarpus fascia has occurred, which may further expand the understanding of the PTL's pathogenesis. In one study of 31 traumatic adipose mass removals, there was no recurrences regardless of treatment method. However, only 6 were later identified pathologically as post-traumatic pseudolipomas without fibrous material. In conclusion, the patient in this case suffered a blunt trauma to the buttocks and subsequently developed a post-traumatic pseudolipoma, which was surgically excised with recurrence months later. While the research surrounding the pathogenesis of the post-traumatic pseudolipoma has evolved from the theory of physical herniation of adipose tissue to an inflammatory differentiation of preadipocytes, there is still much to understand regarding not only this pathology, but the mesenchymal differentiation following tissue injury. Thank you for attending my presentation.